Well, welcome again to our listeners and viewers. Thanks for joining us again in a series of interviews with the experts. I'm Malcolm Bell, your studio host. And this actually is part two of a series that we have enjoyed having Dr. Stan Henkin, who's an associate professor in the Division of Vascular Medicine, who on our last podcast talked about the updated peripheral arterial disease guidelines, why they were important, and particularly sort of highlighted some of the amplifiers and the health disparities of these patients. So welcome again, Stan. And today we're going to focus on intervention for peripheral arterial disease. And I think before we really get into who needs intervention, what type of intervention, maybe important for you to maybe just sort of describe for us the different subsets of patients that you or primary care physicians, advanced practice providers may be seeing in their practice.
Yeah, thanks, Dr. Bell, for having me again. This again goes back to the 2024 guidelines, which really introduced the four subsets of patients with peripheral artery disease. And I think this is how we should be thinking about, again, when we see these patients in our office. And the four subsets are asymptomatic patients, patients with claudication, patients with acute limb ischemia, and chronic limb-threatening ischemia. And let me just go into a little bit more about each patient. Now, the asymptomatic patient is that patient that you get a CAT scan for a different reason, and you see a lot of plaque in the arteries. And you ask them, do you have any symptoms? And they say, no. So although they may have peripheral artery disease, they're asymptomatic from their peripheral artery disease. In those patients, risk factor modification is key. The second patient, and patients that we probably see the most often, is your intermittent claudication patients or claudicants. These patients classically have pain in their calves or their legs when they walk. It improves with rest. Classic presentations, but there may be a lot of different presentations here. Some people have buttock pain, some people have hip or pain and knee pain. So exam and ABIs is critical in these patients. Now, the important patients who we need to be really cognizant of is the acute limb ischemia patients and the chronic limb-threatening ischemia patient. The acute limb ischemia patient is the patient that's characterized by less than 2 weeks of rest pain due to PAD. You can sort of equate that to our STEMI patients. Something needs to be done really quickly about those patients, because if you don't, they're at really high risk of losing that limb. And then the last subset, and the subset that we'll talk about more later on, is the chronic limb-threatening ischemia patient. Those are patients with rest pain or ulceration more than 2 weeks in time. It can kind of equate to your NSTEMI patient, non-STEMI patients, and you need to do something about it, but you have a little bit of time to do something about it. But again, if you don't do anything about it, then the risk of minor or major amputation is really quite high in these patients.
Let's just go back to that asymptomatic group. You said you picked it up incidentally, or could have even been picked up on a physical exam.
Yeah.
We talked about the importance of taking the shoes off, feeling the pulses, but the patient doesn't have any symptoms. Do you consider doing some sort of stress test to make sure that they truly are asymptomatic, like we sometimes do with coronary disease, if we're really suspicious that there is something more serious?
Yeah, that's such a critical question, Dr. Bell, because patients may not realize that they're symptomatic until they do. And actually, again, what's highlighted in the guidelines is the realization that patients curtail their activities so that they don't get leg pain. So the questions to ask when we see these patients is not, do you have leg pain with walking? But it's also, tell me the things that you do now compared to a couple of years ago. And they'll tell you, I just don't play with my kids as much as I do because I get tired. What hurts? My knees hurt, or I'm not able to garden as much as I did before. I'm not able to bike as much as I did before. So people might not realize that slow change. So ankle brachial index is a first great step. And I'll tell you that at Mayo Clinic, we really utilize the treadmill ABIs as a diagnostic test in these individuals, not only because it gives you a post-exercise ABI, but it specifically looks at symptoms. And symptoms are critical because, again, people don't realize what they are or not able to do until you show them, oh my gosh, you had hip pain walking, 1 minute, and your ankle brachial index drops significantly. So I think in these patients, if you're able to obtain a treadmill ABI, which is, by the way, a class 2A indication in these patients, is this is not a screening test, this is a diagnostic test, which is an important implication here. So it's going to be paid for, is very, very helpful in these patients. And a large subset of these asymptomatic patients, you actually realize they're claudicants.
Okay. And your approach then to, we'll come back to the asymptomatic patient later. A couple of things I'd like to ask you. But with respect to the intermittent claudication patient, I mean, what are the key steps that you take in terms of coming up with an initial management plan?
So there's two critical things that we talk about. One is from the medication perspective, one is from the exercise perspective. Now, supervised exercise therapy significantly in every single trial that looked at supervised exercise therapy significantly improves pain-free walking time and total walking time. Many cardiac rehabs now have supervised exercise therapy as part. You may just not know about it, actually. And the important aspect here is Medicare pays for it. They pay for all of it. There is a copay, unfortunately, but it pays for up to 60 sessions of supervised exercise therapy. So please, please, please refer your patients. Actually, when a Medicare population was looked at nationally, only about 2% of eligible patients were referred for supervised exercise therapy. So again, class 1 recommendation. We know it works. Nobody's doing it. Very unfortunate.
And then in terms of indications then for intervention in these patients?
So a couple of things that you think about. One, did they do supervised exercise therapy, or at least did you talk to them about a community-based program or a program that they can do at home, and what happened? The other thing that I really do try to do is use Celestazol, which does improve total walking time. The issue with Celestazol is GI upset and diarrhea. About 50% of individuals do have diarrhea and they stop because of it. So that is a limiting factor. Now, again, as we talked about during our last discussion, there is now semaglutide that's probably going to be approved for this indication as well. So we have another medication to trial, which is going to control other risk factors. So that's going to be a key aspect as well. So my go-to is, if we have tried at least one of these things and the patient gave it their all, we really try to give it their all. If they are significantly limited by their symptoms, we got to think about intervention. And so that's kind of where the lifestyle limiting claudication comes in, meaning they cannot do things in their everyday life that they need to be doing. And that's things like a job. A construction worker, a miner, a farmer, whatever it is, they need to be walking, they can't. We got to think about intervention for those patients.
And you already mentioned the limb-threatening ischemic patient. I think you talked about 2 weeks of increasing symptoms, rest pain. And in those, are there any other alternatives other than to consider intervention, whether it's surgical or endovascular?
Well, and this is something that's discussed at many interventional cardiology, interventional radiology, and vascular surgery meetings, that sometimes major amputation is the best way to go in some patients who are not candidates for endovascular intervention or surgical intervention. In some patients who have significant tissue loss, that's the best way to go to heal. But here's again where we sort of loop back to the health disparities in peripheral artery disease. Nationally, up to 50% of individuals who get major amputation never had a catheter angiogram and never had a trial of intervention with a surgical or endovascular. So we're seeing way too many patients who are not even offered anything before they receive a major amputation. And again, think about all these health disparities: depression, anxiety, need to work, medications, need to take care of family, and we're giving them a major amputation. We're doing them quite a bit of disservice. So a very small subset, but that is critical to discuss in multidisciplinary panel with your vascular surgeons, podiatrists, vascular medicine, cardiology, before you do go on to a major amputation in these patients.
Yeah, and you mentioned imaging there, and perhaps I should have asked you, even go back to that intermittent claudication patient. At what point do you do imaging, such as CTA and other forms of imaging?
Yeah, and that's a really good question because some individuals are used to doing ultrasounds to start with, to diagnose peripheral artery disease. And I would like to highlight, as we very well know from the coronary literature, there is difference between anatomy and physiology. And sometimes anatomy doesn't equal physiology. So you see a velocity step up on an ultrasound, more than 50% stenosis. Well, they have to have symptoms because of that, but that doesn't mean that their physiology is that of a stenosis. So the current guidelines really do say that you do not need to image them until you're considering intervention. So in your claudicants in whom you're going to manage medically, all you need is an ABI, whether that's a rest ABI or an exercise ABI, and you can just follow them that way. Then when you're considering intervention, you have a choice of an ultrasound, CT, MR, or going straight to invasive angiography at that time.
Those are really important points because we don't want to overutilize
Yep.
imaging, which is expensive and often gets repeated. That sometimes necessarily, but sometimes not. But so the key point you're making, you don't really need to do any really detailed imaging unless you're considering, or until you're considering doing some sort of peripheral intervention.
Absolutely. And we do get quite a bit of referrals, both internally and externally for patients who are diagnosed with peripheral artery disease on their CT scan, for example. And we get ABIs and they're normal, or they're near normal. And those populations are very different, again, compared to populations with moderate to severe decrease in their ABIs and maybe less plaque, for example, on their CT compared to other individuals.
So you mentioned that fourth group, the chronic limb-threatening ischemia. How does that differ from the group before, the acute things? I mean, are these people that were failed treatment or didn't have treatment options, or was a delayed acute? I mean, I'm just a little puzzled how you distinguish those two groups.
Yeah, that's a really good question. So if you think about the acute limb ischemia patients, think of it as acute plaque rupture resulting in sudden onset vessel occlusion. So the way that these patients presents is, you remember going back to the medical school, is the classic 6 Ps that have to do with pain, decreased sensation, decreased motor function. So these patients will come in with several days of severe pain, inability to feel in their leg, inability to start to lose their motor function. So those patients have complete occlusion of an artery, whatever artery that is, and they need to be intervened on right away, because if they don't, you're going to lose that leg. We're not talking about toes in that instance. The majority of those patients get a below or above knee amputation. So
very
critical.
Yeah, so that seems obvious. And so then getting back to this fourth group, how do they typically present? How do you identify those? Are there ways of identifying those patients even before they come to a vascular surgeon or interventionalist?
Yeah, absolutely. So I'll give you good news to start. And the good news to start is only about 5% of patients with intermittent claudication will develop chronic limb-threatening ischemia. So that's good news. This is not majority of our patients. But the way that these patients will present is that over time, instead of pain with exertion, they will start saying, my leg hurts when I'm just sitting there or doing nothing. It's waking up at night, and the classic, I need to dangle my legs so that my pain goes away, because you get blood flow with gravity down to your lower extremities. And then over time, the pain can be significant, but patients actually think that it's normal and it's just part of their peripheral artery disease. What really gets patients in the exam room is usually an ulceration that develops, especially diabetics. They hit their toe on some furniture, or they slip, get a little hematoma in their toe. They can't feel anything. Over the next couple of months, they develop a significant ulceration because they can't feel much and because they don't have any blood flow. So that rest pain over 2 weeks that's increasing, or a new ulceration, is the definition of chronic limb-threatening ischemia.
So that brings us to now, what are we going to do with those patients? I mean, I'm presuming at this point you are sort of pulling out all of your imaging that's going to be necessary to decide upon appropriate revascularization. I mean, that's really what we're talking about here. And that brings up the trial results that were published, I think, a couple of years ago for the BEST CLI trial, big international trial comparing endovascular revascularization versus surgical revascularization. So maybe I'll just ask you if you could just briefly summarize who are those patients in that study? What exactly were they looking at? and then we can talk about the endpoints and the conclusions.
Absolutely. So these were patients with chronic limb-threatening ischemia who were candidates for both surgical and endovascular procedures. Who decided? Well, whoever saw the patient, whether it's a vascular surgeon or an interventional cardiologist, decided were they a candidate for either one of the procedures. So it was a decision up to them. And they were randomized then to either surgical intervention or endovascular intervention. Now, the critical part of this trial that I will just go back to, actually, even from the setup, is that this trial included both vascular surgeons and interventional cardiologists as well, too. So these are multiple fields, multidisciplinary trial that I think is really important because each of us have different tools in our toolkit that we are good at. So this trial really tried to utilize the best tools that everybody had, although that's a different discussion because some of the endovascular tools weren't always the best tools or the most modern tools, but that's different. But this is the first trial that actually looked at this, and I think it does answer a question quite well, what to do with these patients.
And maybe just make sure we set the scene accurately. This is for infrainguinal disease. We're not talking about iliac disease, aortic disease. This is SFAs, profunders, correct?
Could be both. Could be both, actually.
Okay.
Could be inflow disease, and it could be infrapopliteal disease as well. Although infrapopliteal was much less common, but it could absolutely actually be inflow disease in these patients as well too.
I see. And then maybe you just so that population, this is that chronic group you're talking about. These are the people with rest pain, ulceration, and maybe maybe even severe hemodynamic findings. But in terms of the surgery, what surgical techniques were they using, and what techniques were they using in the endovascular? Is it balloons? Is it atherectomy, stents? Could you just give us a feel for what these procedures actually were?
Yeah, so there were two different cohorts actually studied in this population, and this is where the trial interpretation really becomes important. The first cohort was a patient with great saphenous vein segment that could be used for surgery. And so this was patients who underwent surgery using GSV segment compared to endovascular population. Now, the second cohort was patients who did not have a GSV that could be used, and so they used prosthetic graft or some other technique compared to, again, endovascular patients who did not have a suitable GSV graft. The type of surgery, again, was up to the operator. So there was a lot of freedom. This is why this is a nice trial, because there was very little of, I'm telling you what to do, and you need to do it my way. It was really a real world trial where the trialists were told, do the best procedure for this patient. If you think this surgical technique is the best, use that surgical technique. If you think this endovascular technique is the best, use an endovascular technique. The important aspect here, though, is that this trial was published already, a couple of years ago. And I remember sitting in ACC when there was a lot of oohs and ahs at presentation of this trial. But even going back to, 7-8 years ago when this trial was ongoing for endovascular techniques, there was a lot of balloons, but not drug-coated balloons, for example. So that's where the criticism of this trial comes in, saying, well, this is not contemporary management of endovascular techniques. Well, it's the best that they had at that point. You can do these trials every 3 to 5 years, it feels like, with new techniques. So it's the best that they had, but that's the one criticism. But again, it was up to an interventionalist to decide what was the best choice for that patient, and they were free to do whatever they wanted with that patient.
As I recall, it was a very large trial that, and the endpoints in terms of the occurrence of endpoints. I mean, there's a large number of endpoints, so they really had power to look at that. And you mentioned the second cohort. Maybe we just leave that aside, because that was a very different group. It was a much smaller group. But let's just focus on that first cohort. The endpoints, the primary. Maybe you can just remind us. It was a primary composite endpoint. What those components were and what the findings were.
Yeah. So the composite was major adverse limb event, which was defined as an amputation or a need for reintervention, whether it was a new bypass or reintervention, thrombectomy, thrombolysis, whatever intervention for that specific initial indication was. or death from any cause. So it was really powered for those indications. And
Those
again,
are hard, those are hard endpoints. I mean, you throw an amputation there as well. I mean, it's reintervention
exactly.
sometimes can be subjective, but death and amputation, I mean, that's,
And
you know,
that's why it took quite a long time for the study to complete. Again, one of the criticisms, but like you said, these are hard endpoints. Majority of the endpoints that we study in this population is usually coronary endpoints or even stroke endpoints or cardiovascular mortality. Major adverse limb event, it takes more events, but this is a higher risk population. That's why they really thought that they could power this. But certainly took quite longer than they expected this trial to go on.
my recollection of this trial, and it's been a few years since I, first learned of it, was that there was maybe an expectation that endovascular was going to be superior and safer than the surgery. That wasn't the finding, though, was it? Then maybe you could just give us the numbers. I mean, what was the difference?
Yeah, so it's really funny because I do remember sitting in that ACC hall, and it was one of the first trials presented, and I was sitting next to one of the PIs of the trial, who did not look very happy, and I was like, oh my gosh, I totally expected, like you said, endovascular arm to blow the surgical arm away. And when they showed the Kaplan, when Dr. Farber shoved the Kaplan-Meier curve, there was audible gasps from the audience because I think nobody expected that, especially honestly at cardiology conference. Everybody thought that the primary endpoint, the endovascular group, would do better. But in fact, when you look at the surgical group compared to endovascular group, now remember, these are patients that had a usable great saphenous vein. That's a critical aspect to remember. It was about 60% primary endpoint in endovascular group compared to about 40%. So a significant risk reduction in major adverse limb event or death from any cause in surgical group. Now, again, the criticisms come in that, well, there was a lot of crossover from endovascular to surgical. We didn't use our best techniques. Yes, you have all those caveats, but I think that what we really glean from this is twofold in CLTI patients. Point number one, everybody needs vein mapping, okay? Everybody needs vein mapping to see if they have a usable great saphenous vein. I think that that's really critical. That is probably not being done out there, and this trial proved it, absolutely proved it. I think that nobody is saying no to that. The second point that this gleaned is there is a time and a place for everything. And endovascular techniques have a time and a place, and surgical techniques have a time and a place. And this is where limb salvage centers, those multidisciplinary discussions between vascular surgeons and cardiologists are critical. We use trials to provide options to our patients, and every option and every patient is different, but we need to provide those options. So I think that this is what this trial really showed. Outside of that, there is still a lot of discussions at every single meeting about, well, do we know, is surgical best? Is endovascular better? Did we really answer the question? Every trial is like this, but I think that this is really critical aspect of our care of these patients.
Yeah, it's easy to criticize these trials, but on the other hand, it takes a lot of time. It's very difficult to recruit patients. Technology interventions change, and even among the endovascular people, to try, you really need to have evidence that drug-coated balloons, stents, atherectomy, all these things, how do they actually compare? What is actually the optimal approach? I don't work in that field, but I can imagine that there's still a lot of interest there. And it's clear that, you need more trials like this. I mean, these are also open label trials. I mean, everyone knew what had happened. It's pretty obvious, but...
And the nice thing I'll just highlight from this trial, since this trial has come out, there has been significant number of post hoc publications about answering all sorts of questions that I think are really important in this space. Again, optimal medical therapy, type of procedure, who intervenes, infrainguinal versus suprainguinal, for example, what's happening. So this was just the beginning of really the transformation of our care of these patients.
Yeah, that's probably a good way to end our discussion and with that statement. And although that percentage difference that you presented there, I mean, that's a number needed to treat of about 5. So there's nothing sort of subtle about this. And these endpoints are obviously occurring in at least 50% of patients. So I mean, these are patients who have a very high frequency of these hard endpoints. And again, as I recall, the procedural complications, whether it's endovascular surgery, were actually very, very low. They're about the
Yeah.
same. And it's not as though there were a lot of patients then dying of MIs, in their hospitalization. So I think that gain sort of tells us that, in the hands of good surgeons with, the good preparation, good endovascular operators, you can do these procedures really quite safely in these, obviously carefully selected patients.
And I would like to just end at one final point is, as we think about the mortality of these patients and the 5 to 10-year mortality, 10-year mortality of probably 50% of these patients, I'm not a hematologist oncologist, but think about how many cancers nowadays have 50% mortality over 5 to 10 years. And these are patients with peripheral artery disease. So we need to do better, and we have options to help them, but we really need to do better.
Yeah, and so many of them die of cardiac disease as well, because it's, as you said, it's sort of a polyvascular, disease that they have. Stan, we could talk for another half an hour or so, and obviously we're not going to do that. Maybe we can have some follow-up here. And I think, when it's really good to have seen that trial be conducted and published, the post-hoc analyses that you emphasized, but I think it also really should be opening the door for more of these trials, and I look forward to getting more information. So thanks again for all of your experience and expertise and sharing that with our listeners and viewers. And I'm sure that everyone appreciates the pragmatic information they received. This is such an important topic, as you've outlined, just because of the prevalence, and particularly in terms of the prognosis of these patients. So thank you.
Thanks, Dr. Bell.
I look forward to having our listeners and viewers join us in future podcasts of interviews with the experts from Mayo Clinic Rochester. Thank you.